It's the Pain Exam Podcast with your host, David Rosenblum, MD. If you treat pain or have an interest in pain management, join us as we discuss painful disorders, alternative treatments, practice management, and more. Be sure to subscribe to the Pain Exam newsletter at painexam.com and review the podcast on Stitcher or iTunes. Our high-yield premium episodes are now available on the Pain Exam app with a premium subscription, or access for free with a CME subscription at painexam.com. And now, without further ado, here's your host, Dr. Rosenblum.
Welcome back. Hope you guys are all doing well. I'm personally coming off of a shoulder injury, and that's why this podcast and the previous are somewhat related to shoulders. And, it's kind of a funny thing when you're the patient, right? First of all, some of the stuff I do on patients, which works for them, doesn't always work for me. I had a partner give me a suprascapular nerve block for my shoulder pain. It didn't really do much. I basically was traveling, and I think I moved my suitcase the wrong way. And I think I tore my infraspinatus muscle, and which was later confirmed with an MRI, so I shouldn't say I think I did. The radiologist completely wrote a book about my shoulder, but the orthopedic seemed to be quite unimpressed and think that it was overread. But that being said, I did have hydroxyapatite deposition disease, calcifications, as well as some infraspinatus tears. I mean, I self-diagnosed myself, had some external rotation, and figured it was either infraspinatus or teres minor. Teres minor is very rare to have a rotator cuff tear. Infraspinatus is also not as common as supraspinatus. However, it happened. Thank God, no full thickness and no surgery in the near future, according to the orthopedic. I got to tell you, I don't know if you've ever had shoulder pain, but it could be quite miserable. And I've had shoulder pain before, but nothing like this. I mean, sleep was impossible. And I'm still not completely out of the woods, but I did get a steroid injection near the infraspinatus tendon, which appeared to be quite helpful. And I am taking, which I never really had experience with, I tried a lidocaine patch for costochondritis in the past, which didn't do anything for me. However, for the shoulder, I'm noticing it is helping. So I do have to take my hats off to those people who create the lidocaine patches. And I wasn't going to plug any one company. However, it was the ZT Lido that actually helped. So hats off, as well as some NSAIDs, of course. And the plan is probably PRP once things die down. Now, funny enough, I did have my receptionist who's in college having, I think, biology or biochem type major or whatnot. She has a class being taught by a neurologist, and her neurologist instructor told her PRP is just a gimmick for doctors to make money, and there's no evidence to support it. So if you've been listening to my podcast, I'm sure you know that that is not true. There's plenty of evidence. The evidence may not be as good as we'd like, but if you look at the amount of independent studies out there, overall, I'd say, from my point of view, it is positive. In addition, everybody uses a different PRP kit. And I've seen people do PRP kits with test tubes, or PRP with test tubes, not even really a kit, and they'll charge $100, $200. And I've seen people charge $1,000 upwards with the more expensive kits. And I have to say, from my experience, you do get what you pay for. I do find that the more expensive kits, not to plug any one company, are better. Meaning if they could give you a higher platelet yield, which, by the way, you can control that. It's not about the kit only. It's about how much plasma you leave in with the platelets, right? But still, if you have the ability to have a high level of control over your platelet counts based on your ability to isolate them and then give as much or as little plasma as you want, that's key to this. So that being said, to answer this neurologist, I printed out ASIPS guidelines, which now they're actually a few years old when they were published about biologics in the spine, but then there were plenty of other studies since. And on top of all that, when we're talking about ethical, safe care, what's preferable? A drug made in a factory, which could be predisposed to all sorts of contaminants, or platelets which are coming from your own body, which are also, hopefully, there is a kit involved, so of course that could be predisposed to some sort of contaminant, however, much less likely, and in my opinion, it's much safer. So I am doing a lot of PRP, and I do believe in it. It's the choice of injection for my own problems, for my knee, probably soon the shoulder. So that's just me going off on a tangent about that. Once again, just a reminder, we do have courses every month. Just check out painexam.com/events or go to nrappain.org for more information. We also have the virtual pain fellowship, which is great for anyone who wants to learn interventional pain or pain in general, as well as study for the boards, because it's quite comprehensive and has a regenerative medicine course involved in it. And we are running ultrasound courses and regenerative medicine courses in the near future. November 11th, if you can't come in person, just go online and you could watch the Zoom for the regenerative medicine course I'm running in New York City. Okay, so let's talk about hydroxyapatite deposition disease. And there's inflammation, discomfort from the disease in patients, usually occurring in a joint. There's calcifications occurring also on the tendons, and the disease is also alternatively known as calcific tendinosis, calcific periarthritis, peritendinitis calcarea, calcific peritendinitis, calcific bursitis, hydroxyapatite rheumatism. They're all related or more or less characterized by calcium hydroxyapatite crystal deposition in tendon, joints, and other soft tissue. It can be asymptomatic, self-limiting, and there's an inflammatory process which usually occurs in unusual locations, and it can imitate trauma, infection, or neoplasms. It can be misdiagnosed, and the prevalence is higher in females to males 2-to-1. The etiology is not entirely understood. The precalcific stage involves changes of the tendon cells that predispose them to calcification. The calcific stage is marked by actual deposition of calcium hydroxyapatite crystals in the tendon. The post-calcific stage involves the resolution of calcific deposition and the healing of the tendon. So there's different explanations for the 4 proposed pathogenic pathways. One is degenerative calcification with key players, tendon, vascular ischemia, trauma, and the deposition of calcified material. Then there's a reactive or cell-mediated calcification. Key players here are chondrocytes, phagocytosis cells, and there's calcium deposition and reabsorption of calcified material. Then you have process similar to endochondral ossification in the cartilage and bone with abnormal calcification within soft tissue, and then erroneous differentiation of tendon-derived stem cells. Tendon-derived stem cells include chondrocytes, osteoblasts, and the development of hydroxyapatite deposition disease due to calcium deposition. Now, my reference will be included in the show notes. It's quite long, and I don't have time to go through this whole thing. But I gave you 4 basic pathways. They go in depth on each one. If you want to geek out on that, you can. The predisposing risk factors for hydroxyapatite deposition disease are diabetes. It's a metabolic type. Increased oxidative stress and chronic low-grade inflammation are secondary to the diabetes. Thyroid disorders, there's just a disruption in metabolic regulation. Estrogen metabolism disorders, imbalance in hormones affecting bone health, and then HLA-A1 genotype, which is potential immunological components being involved. The stages we mentioned, there's the precalcific phase. It's asymptomatic. You can't even see it on the radiographs, but what you have are impaired perfusion and resultant focal hypoxia, triggering fibrocartilaginous transformation. It's marked by, and then the calcific stage, which is marked by deposition of the crystals. Further subdivided into formative, resting, and resorptive phase. Acute pain during the resorptive phase can occur. Visible calcification, especially during the resorptive phase, and then post-calcific occurs from the void when the resorptive phase of the calcific stage is replaced by granulation and scar tissue, and the resolution of the disease. Healing processes visible on the imaging. There's healing process visible. Calcifications are typically absent. So let's just skip over to the treatment. Because it's a lot to talk about here, and there's some nice images on X-ray and ultrasound showing what you can expect to find in these patients. But in terms of the treatment, well, like any sort of orthopedic condition, you're typically going to do rest, ice, NSAIDs, maybe some physical therapy. Of course, for the workup, you want to have your imaging. You want to understand exactly what's going on. Some specialists may perform needle-guided aspiration or lavage to remove the deposition. The procedure involves usually an ultrasound. You can aspirate calcific deposits or break them up, and you could alleviate the symptoms, promote healing with this. Typically, surgery is a last resort, as with pretty much everything orthopedics. Here they also mention that you could use extracorporeal shockwave therapy and surgical interventions if need be. Use the sound waves to break up the hydroxyapatite deposits, facilitating their reabsorption. It's effective in cases where the deposits are near the skin, and it can be a quite innovative approach to the treatment. I never did this. I have heard good things about it. And once again, the NSAIDs, by the way, they, as you know, reduce inflammation, alleviate pain, inhibit the production of certain inflammation-causing chemicals in the body, and that can lead to improved range of motion, comfort, etc. And sometimes you don't need to really do much. You just let the patient heal on their own. As far as PRP goes, I did find a case report, so don't get too excited. It's just a case report. 44-year-old woman with calcific tendonitis of the shoulder treated with PRP injection. Prior to this, she had no improvement of symptoms after 6 weeks of ultrasound treatment, Codman exercises, and anti-inflammatory treatments. PRP was injected into subacromial area 3 times at 2-week intervals. She had progressive improvement of pain at 2 weeks and was asymptomatic at 6 weeks. Patient then underwent previous protocol rehabilitation. At 1-year follow-up, patient was pain-free, had complete resolution of calcific tendonitis and full range of motion, and resumed all activities. So once again, that's just a case report, and yet, unfortunately, I am not yet seeing any randomized controlled trials with PRP. There's another study showing some potential for PRP, but they're actually citing the case report I just mentioned. So I think the jury is still out. However, PRP may be less risky than steroids in the long term. So once again, if I do PRP for myself, I'm doing it for the pain and inflammation to replace the steroid. I'm not expecting any calcifications to disappear from it. Would be nice though, right? Anyway, thanks for listening. I really appreciate you guys. Please, if you have a minute, rate the podcast and share it with your colleagues, and stay safe. Hope to see you guys at the upcoming meetings. NICIP, NANS, Aspen, EPA, everything between. West Virginia SIP, I'll be there teaching ultrasound. And once again, if you have any board prep needs, go to painexam.com or NREP now. Everything's on the nrappain.org, nrappain.org website now. I moved it over. Pain Exam still works. You could still go there, but I'm adding more and more content to nrappain.org, and you'll have the opportunity to get access to the full regenerative pain medicine course that will be there. So, and I'm keep adding to it. So it's going to be more stuff every time I get a chance to upload content to that website. Anyway, thanks for listening. Hope to see you guys soon.
Dr. Rosenblum is here solely to educate, and you are solely responsible for all your decisions and actions in response to any information contained herein. These podcasts are not intended as a substitute for the medical advice of a physician to a particular patient or specific ailment. You should regularly consult a physician in matters relating to yours or another's health. You understand that this podcast is not intended as a substitute for consultation with a licensed medical professional. Copyright 2017, David Rosenblum, all rights reserved. No part of this publication may be reproduced, stored in a retrieval system, or transmitted in any form or by any means, electronic, mechanical, recording, or otherwise, without the prior written permission of the author.